I hit recorded file, whether or not it recorded yesterday.
Just a lot of people. It seemed like it was recording when we were on here.
So
Yeah, like
it may say great
this
things
was
about
showing up.
Yes,
So
okay, awesome. We're so grateful to you guys. Thank you so much.
of course.
Cody comes in and gets MVP of the conference. Not sure.
Just for sitting here and looking.
That's not sure any member of the pack has ever done that as they showed up.
Hey, I don't know what you're talking about. I was always MVP.
Yeah, me too. Yeah, I think we're in pretty good shape. I'm gonna tell everybody to ask me. Really cool. Selection.
Oh, is there Canva? Is there an app for Canva? Like, can I have it on my phone? That's too bad.
And you just refer to this.
Who is singing?
That's too late. No.
Yeah.
Everything works.
Everything was going great, and then so everything's gonna be great. Once for that.
I know.
Just weird enough to understand
I had it.
I think a lot of stuff that about relative tension. And then it's just a little bit.
Nice.
Sheesh.
Remember, I started a brochure. Second for mental health resources in Lewis and Clark County. I'm not doing it. But so, like, this is the front and the back, right? When you're making a brochure, like, that would be like what when it's all closed up is on the outside. So that would be the good a front page, back page. What would you even put on back page for something like that? Maybe just Mini Workers logo.
Like a description or something, like their mission statement.
Mission statement logo. And I didn't even know what's taking credit for it. Oh, just I work hard for it. But then the only one I got so far on here is our place, but I figured I could try to find all the those places too. That's when you eat the guide.
Try to serve everybody.
Why?
With it all
I
on.
don't know why, but just because.
You could also on the back page, you just put other resources that aren't necessarily.
Make a health one, a housing one, and a food one.
Yeah, then you could put like on that back page, you could put other resources and just put the names. So for the mental health one, you can put the housing and the food one,
On the back
on the
without
back.
like logos and stuff, just
just like a list, and like
Oh,
additional
like
housing
on
resources and list them, and additional food
websites,
resources.
maybe. Just put the link to the website or something.
Mhm.
Not that a link matters, but
So remember in a link.
You want to do that next year?
URL, I guess, is what it is when you print things off.
Could be a wall of wall. Highway usable.
Even if white is
We brought us like that from.
being less human, the world in Montana.
Who?
Jen.
She
Gonna be some missed by the community. Washington in December. Their beach. First you all,
We're gonna close the talk to.
but I heard always remember a year or two that
Yeah,
careful, I'm just gonna let her teach this semester and try to get her back here. I'll never teach a Karen. She's back in that. Because nothing to do with that.
Yeah. About time Carol was something.
Uh-huh.
Thank you. I did. So be is 20 years in bed. Literally, we'll say 8%. Yeah. Through like, yeah. That's
Yeah.
like, that's right. Yeah, it was up to you. Thank you. I got it. No, you will, you will. No, please.
Here's the election.
What's this yesterday? I have something better. I'm trying to figure it out. My computer.
MVP of the conference. I was here. This is true. I told you.
Yeah, sorry.
Darn.
Yeah.
No, you did all that. I know 5 seconds when you were doing a focus group.
You know.
We're pretty long. Awesome. Valley of Jolly Green Giant.
It's hell not nice and the receipt.
Matt.
Oh yeah.
He wouldn't mind the company.
Come on.
Yes. My mustache is just this.
Mm-hmm. Eat me.
It's 17. My God. You know, was deep. Yeah.
Gotta get my street.
I didn't do this good.
Just said yes. Extremely high. I figure out smart.
That's
I need you. They've also said, yes, the light air. Being that out. We had a really festival for you. Really. Why? That's wrong. But I think realize we're making that happen.
Good painting on it. Yeah. They don't Oh, he feels like a little baby. So. Oh, well, I'm so grateful.
I think I took from.
Dang, you did too.
Please tell your wife. I think. You guys have been here for it. It would be nice.
Take the lab test.
That's exactly right. It says that. Wait. Also, to
And we.
They'll be here. Yeah, we're gonna be here. Dog.
Wow, I don't want to see that.
Needs to know when the John Tester's gonna be here.
Check the seat just right. Yeah, go back for it. And so
Good morning, Matt and Colleen. This is Kim.
yeah, it's been great. Probably radical. It will be speed.
It's my mom's here.
Good.
Didn't get it. I just corroded. Yes. It's like a centimeter long too.
What's that?
So much chance that it's tomorrow we're here to talk about papers. Yeah. Yeah.
Yeah.
I can't. Yeah, I can see right there.
Thank you. Hi, everybody. Thank you so much for joining us again today. All right, no video games during the conference. So thank you so much for being here and for everything in the past 2 days. It's been really remarkable. And we're excited for this set of speakers. I do want to take a second to thank Gary and Santa Hellish for all their work that they've done over the years to set up this conference. And to Colleen Ron in the back, if we could give her a round of applause. I can absolutely assure you that none of this would work if Colleen wasn't in charge of it. So, thank you. I'm really excited about today's speakers. You know, we're gonna blast this morning, going through it, and but we do have one slight change. We are not gonna have a break after this presentation. So if you need to go take that break on your own, and we are gonna have like we had said, Senator Steve Baines and his staff speaking yesterday over video. Senator John Kester will be here in person at 10. Wow. And everybody pay attention to this part. We get really good speakers because we're really nice and we're supportive. And we don't ask me questions. We don't attack people. We don't ask election questions or I'll get in trouble. Okay. So I'm just saying like this is a great opportunity to meet somebody that's worked with us for decades and not the only policymaker from Big Sandy in the room. So please just be really careful not to ask any election questions. Okay. So thank you to everybody, and I'm really delighted to introduce our first speaker, Dr. Bob Sise. And I never read the bios of anybody, but if you want to find a lot of education credentials, read the full bio. I mean, it's impressive. But for me, what's impressive is, as I said yesterday, there's a group of clinicians around the state that came out of COVID and said, we're going to do things differently. Like Dr. Heather Zalewski yesterday, folks from Browning that are starting up a co-occurring treatment center. Like they want to deliver care better. They know that the techniques are available to reach different parts of the state. And if you could have told me a decade ago or 15 years ago, the co-occurring psychiatry could be delivered in all of these different parts of the state, I would not have believed it. I would have thought that we'd have to set up a medical school or do all of these things. And I just am incredibly grateful to Dr. Bob Sise and to his team. And I can say my family uses them. We trust them because that's what it's all about, is caring for the people that we love. So really grateful to Dr. Bob Sise, and he left his vacation early from Puerto Rico to come to this conference, to meet with you and to share with us. So if he gets divorced, we're gonna see if somebody had the house. She came here with me. So they flew from Puerto Rico to Bozeman and then drove from Bozeman to here to come to our conference. So thank you, Dr. Bob Sise.
Thank you so much, Matt. You're too kind. I was sure to bring her breakfast in bed this morning. So, as you touched on, Matt, this is again a story of how we can do things better. And we'll talk about what we've done as an organization for Six Recovery to assess, meet, and better learn about how to serve patients across Montana. Though I think the crux of it all is we want to make sure folks who most need care can get it when, how, and where they need it. And going back to pre-COVID, we thought you just had to turn on telehealth, connect folks to a psychiatrist, psychiatric mental health nurse practitioner, or an addiction medicine provider. And via that telehealth connection, you're good to go. Magic would happen. It helps, but it's not enough. COVID basically upset everything to the point that people didn't have access to care and they ramped up their substance use, their isolation. They needed care more than ever before. And sure enough, the telehealth helps, but it's not enough. So really now we're kind of in the third wave of making things work. And we would love to say this was always planned. Far from it. If anything, it's the determination of key members of our team, our community partners, and community members, like many of you, coming forward and saying, I need this, I need it now, I need it here in my community. So we'll be talking about how to deliver comprehensive substance use disorder and mental health treatments where it's most needed across the state. Quick disclosures, I serve as the CEO and addiction psychiatrist at Six Recovery. I also consult with community medical services, and with Montana Primary Care Association. We'll talk about who 406 Recovery is as an organization and the care we offer. Really don't want to focus on the core questions at hand, because we want to get good answers. So much of what we need to focus on is asking appropriate questions. So to start, what is the need for qualified substance use disorder treatment services across Montana? Second, why does general mental health treatment and SUD treatment need to be integrated? What difference does it make for patients? And then lastly, what kind of challenges do we encounter when working to ensure prompt access to quality general mental health and SUD treatment across the state? Start off with a case. This is an actual patient. We did skew the age a little bit, but was referred to us by Bridget Care. She was in her mid-20s when she came to see us just over a year ago. History of both alcohol and methamphetamine use disorders. She reported having abstained for a few months, but the history was in fact clear, and we're later able to clarify. Taking 2 to 4 on Sandy's day, this is street alprazolam, and of course, like anything else off the street, it can contain fentanyl. Recently learned of her pregnancy, she's 20 weeks pregnant and wishes to carry to term. So a lot of things at stake for this patient. Let's get back to this case, as it highlights many things that we need to emphasize in coordinating care and keeping it patient-centered. We launched in 2022, just almost exactly 2 years ago. We're a nonprofit featuring substance use disorder and psychiatric care across the state, and now SUD counseling. We have several addictions boarded certified physicians, as well as nurse practitioners. The overwhelming majority of our physicians, nurse practitioners, and our PA are boarded in psychiatry. We do have a very experienced psychopharmacologist who oversaw all quality assurance at Billings Clinic Department of Psychiatry. And just recently, we became a state certified substance use disorder treatment facility. We are working to provide comprehensive, integrated care for both substance use disorders and general mental health concerns across the state, offering evidence-based care. We have in-person services in Billings, Bozeman, and Missoula. This is us. We're 18, going to be 20 here in a month, with the addition of 2 new positions there on the far right. And I would definitely say the most important thing to our growth has been making sure we take good care of our people. As we've never posted a position, everything has been organic in our recruitment. And we've been really fortunate with, in particular, many of the nurse practitioners joined us in the last several months. We do now also have a LAC LCSW in Tamara Knotts, who oversees our SUD counseling, and LAC Patrick Ryan, who provides excellent care and is about to launch Roots. We focus on making sure we can reach patients by leveraging partnerships. For better or worse, all too often in healthcare, even here in Montana, where there's not enough when it comes to access, there's an attitude of we need to keep our patients ours, and we can't share. Scarcity. There is no scarcity of need for SUD and mental health treatment across the state. For better or worse, not all organizations feel or think or act that way, yet we have been able to make some partnerships with some other organizations who are like-minded and with whom we share patient care. And that's how we can remain available for those who need us most and really span access across the state. We do practice harm reduction, which in simple terms is giving folks multiple shots on goal, knowing the ball almost always goes in. Be it treatment of psychosis, bipolar disorder, PTSD, depression, and yes, alcohol, opioid, and methamphetamine use disorders. The single greatest determinant of success in treatment is retention. So long as it's safe and treatment is actually increasing the likelihood of survival and improving function, we continue. We currently have 6 providers, physicians, nurse practitioners who are boarded in addictions through their respective boards. And we have 4 more who are studying, 4 nurse practitioners soon to take the boards, and 1 physician. And really thinking about what we can do to increase the access. It's not just within our organization. We've been very, very grateful for partnerships with the Billings Clinic, Montana Psychiatry Residency, affiliated with University of Washington, and the Internal Medicine Residency at Billings Clinic, as well as partnerships with medical schools, PA schools, and nurse practitioner programs. We started out really at the intersect of general psychiatry and addiction medicine, thinking we're going to take care of folks who have substance use disorder, knowing that over 2/3 also have non-substance use disorder mental health concerns. But due to need and where we were called, I would do a lot of general psychiatry. So focusing on the first main concern, I do want to check in on time. Would someone give me a thumbs up when we're like halfway through? We're like 15-minute mark. And please feel free to ask questions. There's way more slides than we can really do them justice. But we're going to focus on what you all are most interested in. So why does qualified substance use disorder treatment matter? Well, some of the worst illnesses insofar as survival and function, and taking those away from Montanans, are opioid, methamphetamine, and alcohol use disorders. We're going to focus on these, how they impact us here in Montana, and look at treatment options. Look at medication-assisted treatment and how it is available in various forms. We can treat opioid, alcohol, stimulant use disorders, even kratom, with medication-assisted treatment. Now, the role of these treatments vary insofar as their relative importance in comparison to psychosocial interventions. 12-step, SUD counseling, contingency management. Those psychosocial interventions are the mainstay of treatment for the overwhelming majority of substance use disorders, especially alcohol, methamphetamine use disorders. But for opioid use disorder, it's medication, specifically buprenorphine, naltrexone, or methadone, that is the foundation keeping people alive. Now, for them to fully recover, they really need access to psychosocial interventions as well. Focusing on opioid use disorder, and I think something that really is telling, this picture is worth more than 1,000 words. Look at that fatal dose of fentanyl that would kill anyone here in this room, even those of us who, for whatever reason, have some degree of opioid tolerance. Pretty darn scary, thinking that fentanyl makes its way into multiple substances on the street, not just what is sold as opioids. There are 3 ways in the opioid epidemic that got us to where we are now, then actuated by COVID, which we'll get to in just a moment. But going up to pre-COVID 2019, the 2000s was the prescription opioid epidemic wave. We saw, thanks to Purdue and others, a huge amount of supply through legal markets that were then also supplying illicit use. Met in the 2010s by heroin, especially black tar heroin, very cheap, potent, innovatively distributed throughout the United States in the 2010s. That increased the number of opioid overdose deaths. And then lastly, in the 2010s, and what we're still living now, the synthetic explosion, fentanyl and its analogs. And we got to the point where in 2019, over 70,000 people died from opioid overdose deaths. And then COVID-19, which we're about to see. But when we think about opioids and their potential to really put us in a bad place in developing opioid use disorder and or kill us, 25% of patients who are prescribed opioids for chronic pain end up misusing them. And then 10% go on to developing opioid use disorder. And in general, a quick way to think about any use disorder, not to belabor the DSM-5, this I think does way more justice. Its physiologic dependence to a substance meets functional impairment. So any evidence of increased tolerance, withdrawal, then impacted work, school, relationships taking a toll. That combination is the use disorder. 5% of people who misuse prescription opioids end up transitioning to heroin and or fentanyl, and 80% of heroin users first misuse prescription opioids. So really, we need to pay attention to the fact that one of the core treatments available throughout our healthcare systems is quite dangerous. So we saw going up until 2017, over 72,000 Americans died from opioid overdoses, with fentanyl really causing the biggest bump throughout the 20-teens.
What was the percentage of the opioid death?
I'm sorry?
What was the percentage of the opioid death?
What specifically? Back on this slide here.
Opioids, how many Americans died of opiate?
So most recently, it's over 100,000. It looks like we're somewhere around 110.
Okay.
It's gotten slightly better. And then comes COVID-19. So if you think about the Molotov cocktail to make any sort of substance use epidemic worse, how about isolating us at home, having us take time out from pro-social activities, including work and sports, diminishing the strength of our relationships, impairing our access to healthcare, and within that, behavioral health SUD treatment services. What could go wrong? Well, we saw throughout COVID-19, everything ratcheted up. 30% increase in opioid overdose deaths. To your question about the percent change, so that much more of an increase, ratcheting us up above 100,000 in the last year. And remarkably, something changed here in Montana. For the first time ever, we increased with the nation. There was relative resilience, call it Montana grit. That changed with COVID-19 to the point that we now, on a proportional basis, are seeing the increases in opioid overdose deaths to match the nation. So talking about treatment, why the huge focus on medication for opioid use disorder? I'm going to show you in very, very clear terms. Opioid use disorder, where it's moderate or severe, kills 10% of people who have that illness every year, unless they have access to medication. So it is much more like diabetes, hypothyroidism, than it is like other substance use disorders, like alcohol, methamphetamine use disorder. And again, for those other substance use disorders, the psychosocial interventions, SUD counseling therapy, if you will, 12-step, makes the greatest difference. So we're faced with a situation where we see people dying, 1 in 10 every year, unless they have access to treatment. And really the breakthrough evidence came from a study right around the time I was born. It was done in Sweden, where they can do public health like we can only dream of. And the psychosocial piece of treatment, in particular, the care management, SUD counseling, 12-step, is a given. Very small study, 34 patients split into 2 groups, 17-17. Everyone got state-of-the-art psychosocial interventions for 2 years. Half received methadone, the other half were detoxed, did not get any medication. What happened? We flash forward 2 years. In the control group, you did not receive any MOUD, no methadone. You saw 2 deaths, 2 incarcerations, a bunch of medical complications, including sepsis endocarditis, and leg amputation, impacted 3, and only 1 in 17 were abstinent from opioids at the end of the 2-year study, versus the methadone group saw a return to work, school, family, function, with 12 out of 17 abstaining from illicit opioids. So thinking about this as a disease way more like diabetes or hypothyroidism than it is like other substance use disorders. And going one step further, a question that comes up, and love to have this discussion at length, although I'm probably going to be bumped by Senator Tester, and with good reason. When do people get to stop taking their treatment? Well, for those of us with hypothyroidism, when do we get to stop taking Synthroid, levothyroxine? For those of us with diabetes, when do we get to stop taking our diabetes medication? And so we are looking at indefinite treatments. And there are some nuances. Do you want to make sure that you're clarifying the diagnosis as moderate to severe? Yes.
Are they keeping the drug of methadone at a cost that most people in this graphic can afford?
It's 10 cents, yeah, it's 10 cents a milligram and frankly cheaper if you're paying out of pocket than buprenorphine Suboxone. Methadone is very cost effective. Part of the reason is it's been around for now 60 years. So it's generic.
Okay.
So Medicaid covers it. And it's the primary insurer. We have 4 opioid treatment programs across Montana, Billings, essentially Bozeman, Kalispell, and Missoula. And the majority, something like 70% of their patients are Medicaid. You got it. Now, to transition to the form of treatments, we use it for 6 recovery, acknowledging methadone. It has some risks. So it's very effective if it's used in an opioid treatment program. But because it is a full opioid agonist, if people misuse it, if they use it in an unobserved setting, say at home, especially when they're starting, they do have a risk of overdose death because they can stack the doses. So it is something that requires active engagement in an opioid treatment program, whereas we're about to see with buprenorphine, it's way safer. And the reason is, we learned when this came out in 2000 that virtually no one was overdosing and dying on buprenorphine alone. So buprenorphine comes combined with naloxone, Narcan, but the naloxone is not bioavailable in any meaningful way. The only reason it's there is to make sure people cannot divert it. They can't inject it. They can't smoke it. As long as they take it by mouth, the naloxone does not enter the system, doesn't have activity. What we saw when buprenorphine debuted in France and here in the US at the same time around 2000, in the US, it was a combined product, buprenorphine, naloxone, Suboxone. No overdoses, no deaths. In France, it was just buprenorphine, so just a monoproduct. There were a few deaths, and the time that they actually took to analyze everything, they saw it was only individuals who were using incredible doses of buprenorphine with respiratory depressants, barbiturates, benzodiazepines. In general, a cocktail that with or without buprenorphine would kill most of us in this room. And the reason buprenorphine is so safe in particular to highlight on this graph here, we have 2 separate substances. On the left, you have fentanyl, and as you anticipate, as you increase the dose, moving along the horizontal axis, the number of breaths per minute decrease to the point that someone stops breathing and will die unless they're resuscitated with naloxone. In comparison to buprenorphine, it is a partial agonist, so it only partially activates opioid receptors, and similarly, people cannot overdose, cannot die. At the most, they're going to take a nap. As the respiratory rate that they have, even at saturation, when people take heroic doses of buprenorphine, Suboxone, they're still breathing enough to maintain oxygenation, and they will be okay once they wake up. So it is a partial agonist. Now, anyone with a DA license can prescribe. So this is available really across the state of Montana. And why we use it, we see the same data insofar as survival that we see with methadone. So this was another study by Keiko, who did the initial study and kept on studying treatment for opioid use disorder for some 20 years. With buprenorphine, they were actually focused on function in this study. They didn't intend to demonstrate what they did, but the outcome was so meaningful, they shared it, and it was overwhelming. Specifically, here they had a total of 40 patients. Like the methadone study, 2-year period, half, 20 patients, got psychosocial intervention with detox, no opioid exposure whatsoever, versus the treatment arm received buprenorphine for a full 2 years in addition to psychosocial. And what they saw,
Yeah, it's recorded.
0 deaths in the
And sharing.
buprenorphine arm, 20% died in the psychosocial alone. So there, again, we see, here is the 10% annual mortality rate without access for medication-assisted treatment for opioid use disorder. Let's talk about meth.
Yeah, videos.
Methamphetamine kills.
This is
Oftentimes it's killing people in combination with other substances, including opioids, but methamphetamine alone, because it causes such a brutal explosion of catecholamines, dopamine, norepinephrine, it causes a lot of havoc throughout not only the brain, but the cardiovascular system, can result in strokes, heart attacks, a bunch of really nasty complications. And we're seeing really over the last 10 to 15 years, a rampant increase in the number of methamphetamine overdose deaths. And here we're seeing disparities by demographics are worsening, in which essentially there's a 6-fold increase in deaths across the board. So now the gap, if you look, use a laser pointer to highlight this, check out the huge gap between Native Americans at the top and everyone else. So why do people do meth? And why is it so hard to treat? Methamphetamine causes dopamine explosion like nothing else. It does it in 3 ways. It blocks the reuptake of dopamine, norepinephrine, to a lesser extent serotonin, similar to cocaine. Like an amphetamine, it causes increased release of those catecholamines, dopamine, norepinephrine. And then lastly, only methamphetamine ramps up neurons' production of dopamine. And the net impact is a dopamine storm. And if we compare what happens in the brain's reward center, focusing in on the nucleus accumbens, which really is Grand Central Station, when we think about reward networks in the brain where dopamine has the greatest activity, you can see nothing compares to methamphetamine. They yielded these results using functional imaging and had participants eat food, play video games, engage in a sexual experience, use cocaine, amphetamine, and finally meth. And we see a 13-fold increase above baseline dopamine level with methamphetamine. And reflecting on that, I think it helps us build empathy for patients and understand why it is so damn hard to treat methamphetamine use disorder, because nothing comes close to methamphetamine when you think about that dopamine explosion and the feeling people get. First-line treatment for methamphetamine use disorder, again, juxtaposing it, contrasting it to opioid use disorder, here it's the psychosocial interventions. And everyone's gonna sit in for a brief statistics lesson. Number needed to treat. Down and dirty, it's how many people need to receive the treatments for one person to experience resolution, if you will, the cure. And here, we see a contingency management the number needed to treat as 5. So use the psychosocial intervention, treat 5 people, 1 will recover from methamphetamine use disorder. Contingency management essentially harnesses the same psychology of a slot machine and uses that to help someone cut back and ultimately stop using methamphetamine. It uses token rewards, gift cards that you use for coffee or maybe non-alcoholic, non-cigarette purchases at Walmart. It gives them in response to people having urine drug screens result negative for methamphetamine. And the amounts of the gift card and the frequency with which it is dispensed varies. Our brains love this, and sure enough, Vegas, Atlantic City has made billions upon billions, really hijacking this operant conditioning that contingency management uses. Here it's used for good. And it costs relatively little, because if you think about the SUD treatment facilities, mental health centers across the state, they already have the upfront cost of the therapists, the infrastructure. Here we're really talking about, you do SUD counseling, you add some gift cards, just a few $100s a year. Let's contrast that to the medication treatment options. So everyone got really excited in the two big organizations, ASAM, AAAP, about this study from Trivedi and co-authors published in the New England Journal in 2021. The down and dirty is they combined long-acting injectable naltrexone, Vivitrol, used it every 3 weeks, and gave max dose bupropion, which is a noradrenergic, ramping up norepinephrine to a much lesser extent dopamine antidepressant. And they thought, hey, this is going to help with meth cravings and give people more control over use. And they were right, but here the number needed to treat was 9. And they weren't focusing on abstinence from meth use, but rather just having 3 out of 4 urine drug screens result in negative for methamphetamine. And the cost? Medicaid does not cover Vivitrol, long-acting injectable naltrexone, for meth use disorders. The cost here is about $20,000 a year. $20,000 a year for a treatment that is not as effective as gift cards for Starbucks or Walmart. In the latest treatment guidelines from ASAM, AAAP, we see mention of using an extended release form of methylphenidate, Concerta. And yes, this is used to treat ADHD. Very conditional recommendations, and they call upon treatment to be at least coordinated, if not directly managed, by an addiction psychiatrist or addiction medicine boarded physician. And really what we're seeing, the value that using methylphenidate, in some cases Vyvanse, it's an extended release prescription stimulant that's hard to abuse because it is extended release. The reason it probably works is a lot of people with meth use disorder have ADHD. And if they didn't have ADHD to start after using a lot of meth, the prefrontal cortex is offline, and they're essentially left with deficits in function that look a lot like ADHD and respond to prescription stimulant. Alcohol use disorder, no surprise, it hits hard, with up to 10% of Americans in any given year meeting diagnostic criteria. Psychosocial treatments really are the gold standard, make the greatest difference, in particular 12-step SUD counseling, motivational enhancement therapy, and management. We have a medication that can make a big difference. Here, naltrexone, which works by blocking the opioids the brain releases when it sees alcohol. It's kind of crazy. Works and can help with opioid use disorder. Here, it's the best treatment we have for alcohol use disorder. And it was really meaningful. We see with the oral form of the medication, I've known this for over 30 years, it decreases the relapse or return to use rate by half. And there's long-acting injectable form, Vivitrol. Medicaid does cover this for alcohol use disorder. In this large study with over 600 patients, they randomized them between placebo plus psychosocial, low dose Vivitrol psychosocial, and then highest dose Vivitrol psychosocial. I want to highlight one thing here. You see at baseline, really high number of drinking days per month. And then flash forward to placebo and the treatment arms, everyone decreases. And you'll see that 2/3 reduction happened irrespective of medication. So really the psychosocial component is making the greatest difference. But where naltrexone, the long-acting injectable form of Vivitrol, makes a huge difference is in helping people reduce further. And for the severe cases, you see about a 2-fold increase in abstinence associated with the highest dose of Vivitrol, the dose that we actually use. And this is really the best treatment we have to offer for those folks who have done their darndest to stop alcohol use, but cannot make it. Oftentimes they're coming to us after the vacation 12-step, AA, SUD counseling. And so really we can leverage that treatment and make a huge difference. I want to turn to the second question of why general mental health treatment and SUD treatment have to be integrated, why we owe this to patients. So unfortunately, psychiatrists or laborers, we really like our DSM-5. And we like to diagnose and think you know exactly what's going on with everyone around us. Not popular at home. That's right. And yet, and I'll say this about my specialty, All too many psychiatrists run from treating substance use disorders. I've even heard, I don't treat those patients. We are those patients. If we are those patients ourselves, our family members are those patients. Our community members are those patients. Substance use disorders with alcohol use disorder alone impacting 10% of Montana, to not treat it is to not provide standard of care. And so really thinking about how patients present in the real world, we see time and time again, just like the data shows here, with meth use disorder, the overwhelming majority of folks have non-substance use disorder mental health concerns and or at least other substance use disorders, be it prescription opioid misuse, cocaine use, binge drinking, cannabis use. And we see about 2/3 have any sort of mental health concern in addition to meth use disorder. Very similar with alcohol use disorder, in which folks who have alcohol use disorder have a tenfold higher rate than the general population having any substance use disorder. Fourfold higher rates of personality disorders, including antisocial borderline personality disorder, bipolar disorder, fourfold times higher. So really, if we're not adequately acknowledging everything is at stake and treating it all together all at once, we're not providing standard of care. And on the flip side, we see with many non-SUD mental health concerns like ADHD, the rates of substance use and other mental health concerns are incredibly high. We see with ADHD, mood disorders, be it depression, bipolar, up to 7 times higher than the general population. So too, way higher with anxiety, any other substance use disorder, and specific substance use disorders as well. And remarkably, folks who have high severity ADHD have incredibly higher rates of other mental health concerns. The last question, we're actually doing good for time. It's going to be time for questions. The last question we want to address is what challenges do we face when the leather hits the pavement? We're making things happen for folks. What can go wrong? What can go right? Where are we? So if there's one thing that we've seen, first and foremost, is partnering with other organizations, oftentimes other nonprofits, though not exclusively, really makes us the most accessible to the patients who need care. And in particular, we've been emphasizing a 2-week turnaround for standard outpatient care, standing daily access for crisis centers, treatment teams for mental health centers, specifically Eastern Montana Community Mental Health Center, where we serve as medical director and provide care for their MACT teams as well as group homes. And we just recently became a state certified substance use disorder treatment facility. Hope to stand up groups here in the next 3 weeks. And we've also, through a partnership with Osco Pharmacy, been able to get out long-acting injectable psychotropics across the state that pharmacists can administer in the pharmacies. And focusing on 3 in particular, and how we got this, it's all about heart. Again, there is no way we could have done even, I'd say, 1/5 of this without the partnerships we cultivated. And it's really happened organically, simply, hey, we see there's this unmet need. For example, at Rimrock, you all need more psychiatric care. Can we help with that? EMCMHC needed more general psychiatric care. Billings Community Crisis Center did not have standing psychiatric care and SUD treatment on a daily basis. We're able to partner with them and see the patients there on site. Detention centers, Lewis and Clark in particular, and FQHCs in Partnership Health Center have been incredibly welcoming. We have been able to see patients within 2 weeks of new appointments being requested. The standard across the state varies anywhere from 3 to 10 weeks. We're able to do this through recruitment, but most importantly, we coordinate with primary care and with other SUD treatment organizations to do transitions of care, where we stabilize the patient, transition that care back, but remain available for any questions or if another consult is needed. But 2 weeks is oftentimes too long. Folks who are suffering from severe opioid use disorder, meth, alcohol use disorders, and some general mental health concerns oftentimes can't wait 2 weeks. And for that reason, we are standing up weekly treatment start groups. This is a treatment model that I kind of grew up in my training at the Seattle VA Addiction Treatment Center. And where my colleague, Dr. Ty Reedbach, the other addiction psychiatrist, saw it done to scale, I think 50 groups over in West Virginia, where patients can come in at a given standing time each week to start treatment, or if they miss their appointment, they can come back in. There is consent for obviously attending a group session and doing that check-in in the group. By and large, though, if you're able to practice it well, it maintains a really respectful environment, gives people access to care, knowing that they can transition to individual treatment once that becomes available, oftentimes within a week and a half. So why the focus on long-acting injectables? Because they work, and they make a huge difference insofar as food function and helping people stay alive, in particular when it comes to buprenorphine and naltrexone. So we're not only talking about antipsychotic medication, we're also talking about substance use disorder treatment, in particular buprenorphine in the form of sublimated Brixadi, and also naltrexone, Vivitrol, that can be used for alcohol use disorder as well as in certain cases opioid use disorder. So all these slides are going to be available. We're not going to go too deep into the weeds, but suffice it to say, a meta-analysis demonstrated what we're seeing here in Montana through our partnership with Osco Pharmacy. Long-acting injectable buprenorphine works. It works better than oral buprenorphine, and it sure, of course, beats placebo because it keeps people alive. In general, a recurring theme is anytime a medication is available as an injection, things go better because it's one thing going right once a month versus 30 things going right each month. Only have to ensure that one dose is coordinated. And you see in this meta-analysis improved employment rates, abstinence, better access, lower rates of criminal conduct and consequences in the criminal justice system. And improve function not only in employment, but also socially with better care of children. In another study on long-acting injectable antipsychotics, no surprise, I think to many of us who are familiar with this form of treatment, you see better function in psychosis and bipolar disorder with fewer hospitalizations, less ED visits. And even though the medications are expensive, they came out to be cost neutral because the savings were so immense in the reduced hospitalization and emergency department care. We partnered with Albertsons in early 2023 to offer all of these long-acting injectables across all their pharmacies. And the first pharmacist administered dose of buprenorphine Sublocade was prescribed by us. That was done at the Billings location. And they have incredible patient engagement support through their pharmacy tech care coordinator, who calls the patient, schedules the appointment for them to come in. And here, COVID comes up again as a recurrent benefit in that thanks to the vaccination push in COVID-19, every pharmacy now has a relatively private vaccine room where patients can receive the injections, which is relevant in particular for the naltrexone injection. It is a gluteal injection, and we want some degree of privacy. And we've seen a ramp up over the last year. In total, over 140 injections were given across the state, now averaging about 20 a month. Over half were Sublocade, buprenorphine, and a good deal also Vivitrol, again, considered to treat substance use disorders, but you can see also a fair number of antipsychotic injections. And the great thing about this partnership, we've been able to reach patients across the state, from Miles City to Kalispell, Missoula, Bozeman, and of course, the majority were administered in Billings, in part because that's where you have the highest concentration of these pharmacies. We are applying through the Opioid Abatement Trust to offer ongoing access to buprenorphine, Sublocade, 2 patients who are leaving prison. As some of you may be aware, when folks go into prison, they lose Medicaid. On release, they don't have access to coverage for any medication, including Sublocade. So there's a huge risk of falling off, not receiving treatment, returning to use, and an extreme overdose and dying. And so we think this is especially meaningful and really plan to leverage this partnership with Albertsons to offer access across the state to folks leaving prison who continue Sublocade. Let's get back to our case again. Woman in her 20s, referred to as by Bridger Care, history of both alcohol and meth use disorders, using 2 to 4 Xannies off the street each day. Learns she's pregnant, 20 weeks pregnant, wishes to carry to term. So remarkably, here we see the huge benefit of comprehensive integrated treatment. We're able to clarify diagnoses and see that the patient does meet diagnostic criteria for both PTSD and benzo use disorder, severe. Provided psychoeducation about treatment options, specifically for PTSD, and did start treatment of serotonergic antidepressant, which is first line, sertraline. Engaged in motivational interviewing, targeting benzo use reduction and cessation, and started medication-assisted treatment for benzo use, gabapentin. Gabapentin is category B in pregnancy. That said, it's less risky than benzodiazepines, which are category D. And here, our perinatal addiction medicine physician, Dr. Mark Mantel, oversaw the care and was sure to engage the patient in a very nuanced discussion of the risks and benefits. Ultimately did augment with low-dose clonazepam taper. Referred the patient to mutual health group and patient engaged in SUD counseling with our LAC, and we were able to coordinate a warm handoff back to Bridger Care after the patient delivered. And the last I heard, she remains absent from benzos and all substance abuse. We think about how we did the takeaways. What did we reflect on? Overwhelming need for qualified substance use disorder and general mental health treatment across our state. General mental health concerns and substance use disorders co-occur. We have to integrate treatment for both to get the best outcomes for our patients. And lastly, by collaborating across those partnerships, we were able to ensure prompt access to quality mental health treatment and quality SUD care. Thank you so much for your time. We have a much more important guest joining us, so I'm happy to yield my time, but I defer to you, Matt.
And I just want to say thanks so much for Dr. Bob Sise. One of the things that I think his ability to generate 70 slides and present them in 30 minutes was amazing. That connection with Eastern Montana Mental Health Center, where they're getting psychiatrists to Eastern Montana to do addiction treatment, that's is amazing. We have struggled forever. There are people on Medicaid don't get the same quality of care as other places, and especially in places that are rural, places that are covered by Eastern Montana Mental Health Center or others. So we're so grateful to Dr. Sise. His team works in Montana all the time. Reach out to him.